Welcome to AETCM, the emergency medicine channel. Today, let us discuss about abdominal tuberculosis. One of the common form of tuberculosis which can be seen in our country. When we discuss about tuberculosis, we have to divide tuberculosis into two major categories. One is pulmonary tuberculosis, that means TB inside the lungs, and extrapulmonary tuberculosis, that means TB outside the lung, including pleural tuberculosis, pleural effusion, lymph node TB, tuberculosis of upper airways, tuberculosis of GI tract like granulomatous hepatitis, peritonitis, ascites, localized TB in abdomen, lymphadenopathy in abdomen. So many different presentations can be there in abdominal tuberculosis. Again, kidney can be involved, genital tract can be involved, skin can be involved. Almost all organs in our body can be involved by tuberculosis. Now we are discussing about tuberculosis and its different varieties. Tuberculosis as such, pulmonary tuberculosis will not be discussing now. Abdominal tuberculosis means it can involve anywhere in the abdominal cavity, like it can involve the GI tract, peritoneum, mesenteric lymph nodes, genitourinary tract. Almost all areas in the abdomen TB can be involved, including prostate in male patients. TB can be involved. Other organs like patient can have granulomatous hepatitis, that is liver involvement, spleen can be involved, adrenal glands can be involved. Patient present with hypotension and discoloration of skin. So Mycobacterium is the bacteria which is responsible for tuberculosis, that reach the GI tract by hematogenous spread or ingestion of infected sputum from lungs, or direct spread from infected contiguous lymph nodes and fallopian tubes. Sometimes infected food material also can spread tuberculosis to the abdomen. Now if you see the abdominal tuberculosis, there are different types again. Peritoneal tuberculosis accounts for 1 to 2% of all TB cases and 31 to 58% of abdominal TB. Patient who is having pulmonary TB also can have abdominal or peritoneal tuberculosis. On examination, you can get tight abdomen with a doughy feeling. Visceral tuberculosis, isolated visceral TB occurs in 15 to 20% of the abdominal TB cases. Genitourinary system is the most commonly affected area there. Liver, spleen, pancreas, all are also involved. In GI tract, that means intestine, colon and all, patient can have jejunal and ileocecal TB, 64%. That's a maximum number of cases you get jejunal and ileocecal TB. In that, ileocecal junction is one of the most common TB involvement. Colorectal TB, duodenal TB, gastric TB, all are in short percentages. And many patients who is having abdominal TB can also have associated pulmonary TB. Sometimes it can be in dormant stage, sometimes it can be in active state. In peritoneal TB, the gross pathology is mainly complete ulcers of the intestinal tract. Fibrosis can occur after sometimes. Thickening and stricturing of bowel can present as intestinal obstruction. Enlarged matted mesenteric lymph nodes can have abdominal pain, obstruction in the GI tract, or obstructive jaundice. Omental thickening, peritoneal tuberculosis can lead to peritonitis. So almost all types of abdominal presentation can be in abdominal TB. Peritoneal TB occurs in mainly three forms. One is wet type, where the patient can have ascites, and on examination it is not like a usual ascites where the abdomen is tensed, but even when it is tensed, if you press it, the pressing can easily displace the fluid. But here it is not like that. It is a doughy field. That means when you press the abdomen, it is like a dough. You can only press it, but it will not. The fluid will not be displaced like normal ascitic fluid. Another one is dry type, where the patient can have adhesions, intestinal obstructions, severe vomiting, abdominal pain, all these things. Third one is fibrotic state or fibrotic type. There the omental thickening and loculated ascites can be there. So these are the three types of peritoneal tuberculosis, but what mostly we see in our clinical practice is dry type. Dry type only, we routinely see wet type. Wet type is the classical presentation of peritoneal TB in our clinical practice. One of the most common sites which can produce tuberculosis is ileocecal junction. That is the most common site in abdomen where TB is possible. Ileocecal and small bowel tuberculosis present with palpable mass in the right lower quadrant, or complications of obstruction, perforation, malabsorption, especially when it presents with stricture. So many patients can present with lower abdominal pain, right lower abdominal pain, mimicking like appendicitis. Some patients can have intestinal obstruction. Chronic ulcers can lead to albumin losing enteropathy. One of the common causes intestinal tuberculosis. So many different presentations can occur due to the ulcerating lesions in the intestine. So again, jejunal and ileocecal, one of the most common presentation of tuberculosis in abdomen, we already discussed. Patient can have diarrhea, colic abdominal pain, vomiting, malabsorption syndromes. All these features can be there in jejunal involvement. You can see here thickening at the ileocecal junction can be seen in this imaging study. So that indicates one of the most common site of abdominal tuberculosis. The patient develops slowly strictures and complete intestinal obstruction. Patient can also have malabsorption syndrome. Chronic ulcers can lead to protein losing enteropathy. So hypoalbuminemia is common. So these are the common presentations, and imaging study shows thickening at the ileocecal junction. So investigations mainly small bowel, barium meal, barium enema tests can be done, X-rays can be done for that. Ultrasound will pick up intestinal obstruction, thickened intestinal loops. Some lymph nodes can be picked up by ultrasound. Again, CT scan and colonoscopy may pick up the diagnosis better than ultrasound. Colonoscopy can be used to take biopsies from the ulcers in the intestine. If the patient develops ascites, it will be on aspiration we can examine the ascitic fluid, straw colored fluid with high protein. Serum ascites albumin gradient is less than 1.1 gram per deciliter. WBC counts in ascitic fluid is elevated more than 1000 cells millimeter. ADA is also elevated in above 36 units per liter. Laparoscopy can be done to rule out other causes, and if there is a lymph node in the abdomen, it can be taken up by laparoscopy. Otherwise, routinely we take ascitic fluid and take a diagnosis. Sometimes we go for colonoscopy and take the biopsy of ulcers. CT scan contrast CT scan can pick up abdominal strictures or inflammation in the ileocecal junction. So these are the common investigation. However, most of the centers fully dependent on the ascitic fluid evaluation and barium enema or barium meal X-rays. Now, one of the important tests in tuberculosis is gene expert. It can detect the presence of TB bacteria, and it can also detect the resistance to rifampicin. So it's a nucleic acid amplification test which can detect TB bacilli, and it can also pick up resistance to rifampicin. We should know why resistance to rifampicin is very, very important, because rifampicin is the one drug which acts against almost all types of TB bacteria. It can act against rapid growers, slow growers, intracellular organism, extracellular organism. So many different types of organisms are there in TB bacteria. So this drug can act against almost all types of TB bacilli, especially slow growers. If rifampicin is not there, these slow growers slowly grow after the 6 months therapy, and it can grow after the completion of treatment. So if we are not able to give rifampicin due to any reason, including the resistance, we have to continue the treatment for 18 months to cover the slow growers. So rifampicin is there, it will act against both rapid growers and slow growers. So we can complete the treatment in 6 months. If rifampicin is not there due to any reason, including resistance, we have to continue the treatment for 18 months. So that is very, very important. So checking the gene expert will give you a faster result of TB bacteria presence in 1 day, and it also picks up rifampicin resistance. Whereas if we send cultures like BACTEC cultures, it takes nearly 6 weeks to give the report. So we will not be able to get the report fast. So here gene expert is a faster reporting test, and it is also very useful for picking up the rifampicin resistance. But once we diagnose diagnose TB by gene expert, we should not repeatedly do it, because it can, even after 1 or 2 weeks, if we are repeating this again, this will show Mycobacteria TB presence, because it can pick up even dead bacilli. So once we diagnose it with this test, we should never repeat the test just to pick up TB bacteria. But if we want to know the resistance pattern after sometimes, you can try it. Otherwise, don't repeat the test unnecessarily. Now we'll discuss about some of the common anti-tubercular drugs: isoniazid, rifampicin, ethambutol, pyrazinamide. These are the common drugs. So you can remember the dose like this: 5, 10, 15, 25. 5 for INH, 10 for rifampicin, 15 for ethambutol, pyrazinamide 25. So 5, 10, 15, 25 is the dose. That means 5 mg per kg body weight is the dose for INH. 10 mg per kg body weight is the dose for rifampicin. 15 mg per kg body weight for ethambutol. Pyrazinamide 25 mg per kg body weight. If we are not able to give any of these drugs, we can give an alternative drug like streptomycin or thiacetazone. So these drugs also can be given. We should know the side effects of these drugs. INH, common side effect is peripheral neuritis, hepatitis. Rifampicin, hepatitis, rash, fever, orange colored urine. Ethambutol, optic neuritis. Streptomycin, ototoxicity and nephrotoxic, but they are predominantly ototoxic than nephrotoxicity. Pyrazinamide, hepatitis, hyperuricemia. So these are the common side effects. These drugs should be given, all 4 drugs should be given for 2 months. That is an intensive phase. After that, rifampicin and INH should be continued for another 4 months. So the total duration of TB treatment is 6 months. So the standard regime I have already told: 2 months HRZE, then 4 months HR only. So INH, rifampicin, ethambutol, pyrazinamide for first 2 months, then rifampicin and INH should be continued for another 4 months. This is a standard protocol. But according to DOTS regime, some alterations may be there, because DOT regime, what we use is we give we don't give rifampicin every day. So that alternation in regime is there, but total duration is always 6 months. So if we are not able to give rifampicin, then treatment is for 18 months. You know what is the reason why we are giving for 18 months? Because we have to cover the slow growers. So that drug, if it is not there in the regime, we have to give it for 18 months. Now, some of the major problems with ATT we should remember that one is, if rifampicin is not there, continue it for 18 months. Almost all drugs like INH, rifampicin, pyrazinamide can produce alteration in the liver function, like SGOT, SGPT can be elevated. If SGOT, SGPT is significantly elevated more than 5 times, we have to stop the drug. If it is less than 3 times and patient is having clinical symptoms of hepatitis, stop the drug. Then rule out other causes for hepatitis, like we should rule out other causes like hepatitis B, hepatitis C or any other viral infection. Then wait the SGOT, SGPT to come back to normal. Then restart one by one drug, like least hepatotoxic is INH, then rifampicin, then pyrazinamide. So most of the time pyrazinamide is the cause for hepatitis, so you can skip the pyrazinamide. If rifampicin is the cause for liver function alteration, then it will be difficult for the patient because he has to take the treatment for 18 months. So hepatitis is one of the most common adverse effects in TB treatment. We have to stop almost all the drugs. So out of 4, we have to stop 3 drugs, then restart one by one in its 25% of the doses, and see SGOT, SGPT is not elevating, then add next 25%. Like that, one drug is completed, we can add next drug. So start in a way that INH should be started, it's 25%, then 50%, then 75%, then 100%, then add rifampicin. Then if rifampicin is okay with the patient, then even most of the conditions 3 drug regime also will be useful. Instead of pyrazinamide, you can go for an alternative drug like streptomycin. Now pregnant woman TB should be treated with INH, rifampicin, ethambutol and pyrazinamide. Here streptomycin is can produce congenital deafness, so we avoid this drug. Breastfeeding is not a contraindication for TB treatment. Now, in emergency medicine, one of the most common problems what we face in TB is the acute adrenal insufficiency. Many patients with TB, including HIV with TB, they present with severe hypotension. So, we should understand that it is due to TB adrenalitis and failure of adrenaline release from the gland. So in that condition, we have to give steroids like hydrocortisone can be given 50 mg QID, that means 50 mg every 6th hourly, or any other steroid can be given, dexamethasone with fludrocortisone, that also can be given. And we should also understand that steroids are useful in conditions like meningitis, pericarditis, massive and rapidly accumulating pleural effusion. All these conditions, if you don't give steroid, that will produce adhesions. So that is a problem. If we don't give steroids in meningitis, patient develops adhesions in the brain and they develop obstructive hydrocephalus. So we have to give steroids even if the patient is having HIV with TB. In these conditions, if you don't give steroids, patient can develop adhesions and chronic complications like constrictive pericarditis, hydrocephalus, obstructive hydrocephalus, and loculated effusions. Eye involvement also we have to give steroids. Genital organ involvement, because if you don't give steroids, permanent damage can occur, obstruction can occur in the genital tract and patient can have infertility. And I have already told, adrenalitis is one of the most important condition where ER physicians should give steroids in tuberculosis. Now, few words about multi-drug resistance tuberculosis. It is resistance to rifampicin and INH. And you have one more entity, that is XDR, extended drug resistant tuberculosis. Multiple drugs are, even second line drugs are also developing resistance. Here we have to use other types of drugs like kanamycin, ethionamide, ofloxacin and pyrazinamide. These are the drugs can be used. But remember, in our country we use quinolones in most of the diseases, where in Western countries they use, because they don't have tuberculosis in their country. So even if they use quinolones in almost all conditions, it is not going to produce any resistance against TB bacilli. But in India, many of our normal patients also having TB bacilli in their body. If we are unnecessarily exposing quinolones to these patients, in future quinolone resistance will become very common. So try to avoid quinolones in any patient if there is no strong indications. So we can use kanamycin, ethionamide, ofloxacin and pyrazinamide as second line drugs. These are the combinations available. You can use aminoglycoside like streptomycin, amikacin, kanamycin, capreomycin with quinolones like ofloxacin. So here dose is slightly higher. You routinely use 400 mg OD in other conditions like urinary tract infection and all. Here 400 mg BD dose is given. Ciprofloxacin 750 mg BD is given. Sparfloxacin 400 mg BD. Moxifloxacin 400 mg OD. Ethionamide 250 mg BD. Prothionamide 250 mg BD. Pyrazinamide 25 mg per kg. Other drugs like cycloserine, PAS also can be given. So we have discussed about abdominal tuberculosis and extrapulmonary tuberculosis. Pulmonary means infection of TB in the lungs. Extrapulmonary means the infection of TB outside the lung, including the pleural cavity. Intestinal tuberculosis can be in different varieties because almost all organs in the abdomen can be involved by tuberculosis. But whatever it is, wherever is the tuberculosis, the treatment is same. According to WHO, it is 4-drug regime for 6 months. Rifampicin doses, there are some difference from the WHO regime to a routine regime, what we give in normal practice. But according to DOTS regime, it's slightly different. Rifampicin may not be given every day according to that regime. Thank you.